my name is Whitney and I am a dental hygienist. If you're new here, welcome. If you've been here before, welcome back. Let's talk about teeth grinding and clenching. And before we jump in, I'd like to quickly remind you about my website, teethtalkgirl.com. If you're ever looking for a specific dental topic, I have a search bar where you can easily find what you're looking for. And also my Instagram, @teethtalkgirl. In the medical and dental world, clenching and grinding your teeth is also known as bruxism. Chronic teeth bruxism, or bruxing, can lead to excess pressure and overuse of your TMJ on either side of your mouth. Ultimately, all of that tension from biting so hard can strain the ligaments and muscles that allow your TMJ to move, aka causing you jaw pain, which leads to facial pain and headaches. Clenching and grinding, or bruxing, can also wear away your tooth enamel over time, which isn't good because enamel doesn't grow back. So how do we stop ourselves from doing this? During the day, if you're doing it, maybe you can catch yourself if you consciously try to watch for it. It's kind of similar to when you're trying to catch yourself slouching, like not sitting up straight at your computer desk. Same thing with your jaw. You might notice yourself clenching down hard when you're working. Try not to. That's the simple fix for it, is once you're aware, stop. But interestingly enough, most people who grind their teeth and clench their jaw are unable to be aware that they're doing it because they're doing it when they are sleeping. When you are sleeping, you are not conscious of what's going on, so you can't just tell yourself to stop. Sleep bruxism is considered a sleep-related movement disorder. People who clench or grind their teeth during their sleep are more likely to have other sleep disorders as well, such as snoring and pauses in your breathing or sleep apnea. So having said that, if your sleep partner or yourself have noticed that you are clenching or grinding at night, be sure to mention it to your dentist at your next dental appointment. Sometimes others who are sleeping near you will hear you grinding, which will help you recognize it, right? But if you are only clenching your jaw and not grinding your teeth, oftentimes you are the only one who is able to try and recognize it. Other than your dentist might notice tooth wear or recession. Other symptoms that might help you figure out if you're clenching or grinding your teeth at night may include pain in your jaw when you wake up, tired or sore jaw muscles, flattened, fractured, chipped, or loose teeth, worn tooth enamel, increased teeth sensitivity, neck pain, headaches, pain that resembles an earache, and cut up insides of your cheeks from biting. Again, please remember that you may have sleep bruxism and still not notice any of these symptoms until complications develop. So it's super important to seek regular dental care so your dental provider can monitor your mouth routinely and clue you in if they notice any of these signs or symptoms in your mouth. What complications can happen? Well, damage to your teeth, cracks and chips, which can lead to needing fillings, crowns, and sometimes even root canals, which can get expensive. Headaches that ruin your quality of life, severe facial or jaw pain, again, disturbing your daily life, and TMJ disorder. You might notice clicking or popping when you open and close your mouth. And lastly, why does this happen? Why are we clenching and grinding? Unfortunately, we don't 100% understand what causes bruxism yet, but research shows it may be a combination of things including stress. That's the big one across the board. Other emotions such as anger, frustration, or tension, coping strategies or a habit during deep concentration, personality types that are aggressive, competitive, or hyperactive, genetics. Sleep bruxism, specifically, tends to occur in families. Bruxism can also be associated with some mental health and medical disorders such as Parkinson's disease, dementia, GERD, epilepsy, night terrors, ADHD, and sleep-related disorders like sleep apnea. Now, sleep apnea is a big hot topic of dentistry right now because sometimes the first hint of undiagnosed obstructive sleep apnea can be from your dentist visit, because people with sleep apnea experience some of the same warning signs and are often known to clench their jaws or grind their teeth at night. So please keep in mind that sleep apnea is a serious thing. So if your dentist has any reason to believe you might have sleep apnea, go get a sleep test. Now, how do we stop clenching and grinding? What's the best treatment? Finding out the root cause of bruxing is generally the best way to find the best treatment. For example, if you're bruxing due to stress is your root cause, stress reduction techniques may be what you need. Cognitive behavioral therapy is a thing, and so is sleep hygiene. And my best advice is to consult your physician or therapist if you'd like to learn more about stress management. So until you can get the clenching and grinding under control, as a dental professional, I care a lot about preventing you from grinding down your own teeth. So I highly suggest for all of my patients that are bruxing at night to wear a night guard to protect your teeth and jaw. I do have a video all about night guards and how they work and how to pick one. If you'd like to learn more, I'll link that video in the bottom bar below. In conclusion, if you're awake when you're bruxing, do your best to keep reminding yourself to stop. Get out of the habit. And if you're asleep, try to find out the root cause to help fix it. And until then, protect your teeth and jaw by wearing a night guard. Pro tip, if you notice yourself clenching a lot during the workday, consider wearing your night guard during the day too, if your line of work allows it, right? If you're not talking to people all day, if you're on the computer or something, it can't hurt to wear it. Your teeth will thank you. I hope this video helped you. Please like and subscribe if it did. And like I said, if you want to learn more about night guards and bruxism, I'll link my other TMJ videos and my night guard video in the bottom bar below. Peace, love, and teeth.
In India, the prevalence of COVID-19 and black fungus infections has increased. What's the black fungus? Why is it associated with COVID? Why is it occurring in India? How is it diagnosed and treated? And how do you prevent it? That's what this video is about. So welcome to another video. If you're new here, my name is Mike Hansen. I'm a board-certified physician specializing in internal medicine, pulmonary disease, and critical care medicine. And if you like learning about health and medicine, this is the channel to click on that subscribe button and bell notification. Okay, what is the black fungus among us? Black fungus is mucormycosis, a rare but dangerous infection. It's caused by a group of molds known as Mucormycetes. These fungi can be found in decaying leaves, compost piles, and rotten wood. Molds require moisture and decaying organic material in order to thrive. Mucormycetes release large numbers of spores that can go into the air. Infections occur more frequently in the summer and fall compared to the winter and spring. People can inhale these fungal spores when they're near moist, dead vegetation. Small, hair-like structures called cilia can catch these spores in your airways and get into your lungs. They can also get trapped in your mouth, nose, and sinuses. You can also swallow them, in which case these spores are harmless and pass through your digestive system. The immune system cleans up any leftover spores. Now, for most people, the vast majority of people, getting these spores in their body is no big deal.
Forget about it.
But black fungus has an advantage in people who have a weak immune system. If your immune system is weak, or your cilia for some reason don't work well, for example with certain genetic conditions, it's easier for the spores to get deep into the sinuses and other body tissues. Once this happens, it's harder for your immune system to dispose of them. Besides entering your body through your mouth, nose, and sinuses, the fungus can also enter through a break in your skin, such as a cut or a scrape. The types of mucormycosis infections depend on where they enter your body. So rhinocerebral mucormycosis is an infection of the sinuses that can occur when a person with a weakened immune system breathes in those fungal spores. Air enters the nose and may go into the sinuses, which are air chambers found in the facial bones. Sinuses are air pockets that serve to lighten the skull, provide resonance for speech, and moisturize and warm the air that we breathe. The infection can spread from the sinuses to the brain or the eyes. People with diabetes who have poorly controlled blood sugar are more likely to develop a black fungal infection of the sinuses. Same for those who've had a kidney transplant. Lung mucormycosis is most common in those with a very weakened immune system after having cancer treatment or an organ transplant. Skin mucormycosis develops when the fungus enters the skin through a scrape or cut in the skin, and this is the most common type of black fungus infection in people who have a healthy immune system. Disseminated mucormycosis occurs when the infection spreads throughout the body via the bloodstream. The fungus invades the blood vessels, reducing blood flow to organs and tissues supplied by these damaged blood vessels. Now, when that blood flow is decreased, the tissues can't get enough oxygen and nutrients, and then they start to die. Dying tissue turns black. Black fungus grows well on dying tissue. After passing through the blood, the fungus usually affects the brain, but it can also affect the spleen, heart, and skin. An opportunistic infection takes advantage of you when your immune system is weak. We use steroids like dexamethasone, aka Decadron, to treat sicker people with COVID-19. When COVID-19 gets into the lungs, meaning COVID pneumonia, the immune system is stirring up this crazy amount of inflammation there, which can do a lot of damage. So we try to minimize that inflammation with steroids. Sometimes, for very severe COVID pneumonia, we also give a drug called tocilizumab, which also makes the immune system weaker. Unfortunately, this can lead to black fungus infection, not just because it suppresses the immune system, but also because steroids increase blood sugar levels. And fungal infections love sugar. Sugar is their go-to for nutrition. People with uncontrolled diabetes have higher blood sugar levels, which helps the fungus grow and flourish. Diabetes is extremely common in India. It's actually estimated that 15% of adults in India's urban areas have it. So why is this black fungus outbreak mainly happening in India? Well, one reason is related to the swelling number of COVID cases, in addition to the liberal use of steroids there. But there are likely other factors as well. Sometimes there are mucormycosis outbreaks in hospital settings. These outbreaks have been linked to adhesive bandages, wooden tongue depressors, hospital linens, negative pressure rooms, water leaks, poor air filtration, non-sterile medical devices, building construction, but also oxygen face masks and humidifiers help people with COVID-19 breathe easier, and they deliver oxygen to their lungs. These devices can make it easier for the black fungus to invade the sinuses and cause infection. The majority of infected people have diabetes and have recently recovered from COVID-19. So according to recent reports, 85% of people with mucormycosis also have diabetes. Of the 222 initially diagnosed, 212 were COVID-19 positive. 29 were not given steroids. 12 were considered to be immunocompromised, and 21 had another medical condition. The symptoms of mucormycosis depend on where the fungus is growing in your body. The most common site of infection in patients recovering from COVID is the sinuses and the brain. The symptoms would then be similar to those of a sinus infection, so facial swelling on one side of the face, headache, nose or sinus congestion, black sores on the bridge of the nose or the roof of the mouth, and fever. So the black sores are a feature of black fungus and are not usually found in more typical bacterial and viral sinus infections. As the infection gets worse, these symptoms can progress to blood-tinged runny nose, bulging eye, difficulty fully closing the eyelid, difficulty moving the eye, visual problems, and black pus draining from the eyes. When the infection involves the skin, there are blisters or ulcers that may eventually turn black. You may also experience pain, warmth, redness, and swelling around that area of infection. These are signs of inflammation which indicate that your immune system is fighting the infection. As a skin infection worsens and progresses, the affected area swells and becomes hard and painful to the touch. It may begin draining pus, form a walled-off infection known as an abscess, or develop blackened areas from dying skin tissue. Symptoms of a lung infection, this would include fever, cough, chest pain, shortness of breath, and since mucormycosis is caused by fungal spores in the environment, it's not contagious. It does not spread from person to person or from animal to person. If you have typical black fungus symptoms, your doctor may take a sample of fluid from your nose or your throat and then send it to a lab to be tested. They may also do a tissue biopsy, which means taking a small piece of tissue and then looking at it underneath the microscope. If your infection is in your nose or your sinuses, a doctor may use a tube with a light and a camera to look inside your nose and sinuses. Blackened or dead-looking tissue makes it more likely that the black fungus is the culprit. So your doctor may also do a CAT scan or an MRI or both to take pictures of your head and sinuses. CT or MRI scans can help find out whether the infection has spread to your brain or other organs. Although rare, black fungus is a serious infection. The sooner you detect it and treat it, the better the outcome. Antifungal medication can stop the fungus from dividing and spreading. In India, doctors are treating the infection with an IV drug called amphotericin B. Now, this medication has lots of potential for side effects, and there's an inside joke in the medical community that it's called amphoterrible. Treatment can take several weeks. So black fungus thrives on dead and dying tissue. In severe cases, as the infection worsens and the tissue dies, it will become black and necrotic. In this case, doctors will surgically remove this tissue to keep the infection from spreading. Some people with severe infections have had parts of their face, jaw, or eyes removed. Untreated, the death rate from mucormycosis is estimated to be 54%. The death rate from the fungus will depend on how healthy the person is, but also whether they have other medical conditions, the type of fungus, and the area of the body that's infected. Also, if their blood sugars are controlled or not. So, if you have COVID, what can you do to prevent getting mucormycosis? For one, make sure your blood sugars are well controlled. 2, only take steroid medications if properly recommended by a doctor. 3, if you're wearing a mask, make sure it's a fresh, clean mask. And 4, this includes CPAP masks or BiPAP masks. Make sure that you clean them properly and frequently. So that's all for this video. Thank you for watching, and I'll be coming out with another one. It's going to be a big one, and it's going to be a controversial one on the origin of COVID. So make sure you stay tuned for that.
Only 6% of people affected with COVID need hospitalization. If our country needs to deal with only this 6%, our death rate would be far below what it is today, and medical care would be available for those who need it. Let's look at the 94% who are affected with COVID and what is their best option.
Doctor, you can mute your audio.
You are tested positive and you have either no symptoms or very mild symptoms, like a cold, cough, fever, body pains, weakness. This means that your immunity is working well against the virus and keeping it under control. And in a matter of 1 week to 10 days, all these symptoms will settle down. You may develop a loss of smell and taste along the way, but you will recover without any complication with simple over-the-counter medications like Dolo 650, home remedies, Ayurveda and homeopathy. Be in constant telephonic touch with your family doctor. Keep him informed on a daily basis. I have treated over 1300 people this way successfully. I strongly believe that over 94% of the people affected with COVID can be treated this way. Where are we going wrong? RT-PCR is the main test for diagnosing COVID, and it is only about 65 to 70% accurate, which means that 30-35% may be positive but will still show as negative. Not testing for COVID. Let us assume that every cold, cough, fever that happens to us now is COVID. We isolate ourselves and follow the rules which are laid down by the government, and we treat it as I have advised above and be done with it in a week or 10 days time. Testing for COVID. Once you are tested positive for COVID, you follow the above line of treatment and be done with it in 1 week to 10 days time. But this is possible only in 10% of those who have tested positive. Let me explain what happens to the rest 90% who are tested positive. Panic. With the second wave hitting us hard and the fear surrounding it, the moment you are tested positive, all hell breaks loose. You are flooded with advice from relatives, friends, colleagues, each one telling you their experiences and all the gory details from the news and the social media, and you get scared. You hardly have any symptoms, but the moment you know you are positive and you hear all their advice, you start to panic. When you panic, your breathing pattern changes. You breathe shallow, and in doing so, you pull carbon dioxide in your lungs and you begin to feel breathless. You are told that the lungs are getting affected, but the fact is that your anxiety is what is causing your breathlessness. Now you are asked to do the following investigations: a D-dimer, a C-reactive protein, and a CT scan of the chest. A D-dimer. Elevated levels of D-dimer are associated with any inflammation and any disease activity. It is only when the levels are extremely high it indicates a clotting problem. C-reactive protein. A high level of C-reactive protein in the blood is a marker of any inflammation. It can be caused by a wide variety of conditions. Both the above tests are not specific.
Health enhances smiles. Good oral health contributes to overall well-being. We at Group Pharma, our purpose is to deliver the best dental and healthcare products and services. We are constantly innovating to offer the finest in our sphere of the industry. In our 40 years of existence, we developed and launched many first-time products like bioactive glass toothpaste, the unique xylitol-based kids toothpaste, the phytoenzyme toothpaste, and the nanohydroxyl appetite toothpaste. We have made a significant impact in alleviating specific oral conditions. Our dedicated field force, supported ably by our energetic and enthusiastic back office experts, market the products. Manufactured at our CGMP and ISO compliant factories located in Bengaluru and Mumbai. Our oral hygiene products help bring healthy smiles across the globe. Our commitment to spreading smiles beyond business. We have the legacy of partnering with the community, and with every smile, we realize our purpose. We symbolize the two most important beliefs we have: growth in every aspect and the people we touch. We at Group Pharma live our purpose of delivering the best oral and healthcare products with the firm conviction that every healthy smile matters.
My head. It is hurting so much.
Hey, it seems you're not being looked after properly.
But Peter takes good care of me. He brushes twice a day and does not eat too many sweets.
Still, you have cavities, my friend.
But why?
Because Peter's toothpaste doesn't have xylitol.
Xylitol?
Xylitol is the friendly sugar that gives sweet taste to the toothpaste without damaging our teeth. Unlike sugar in most toothpaste, the bacteria in our mouth is unable to absorb xylitol. As a result, the bacteria cannot multiply rapidly and release any harmful acid that cause cavities.
Oh, really?
The power of xylitol in Pediflow Kids gives your children a healthy and a sweet smile.
Dr. Mahesh sir? Dr. Mahesh sir?
Yes.
You can please put your video on. I will just do a few introductory slides and I'll hand it over to you. So warm welcome to all attendees. Thank you so much for coming in right in time, and we are starting at 5 p.m. as promised. Warm welcome to the presenter of the day, Dr. Mahesh Chauhan sir. Thank you very much for coming in. Yes, we at Group Pharmaceuticals not only believe healthy smiles matter, but we also believe laughter is the best medicine. In fact, traditionally, various people have been famous for creating laughter. Like we had the champion of humor. He was known as Vikatakavi, and that was Tenali Raman. It is a question of being, comic, so that it creates a pleasant sense of state of mind. Very interesting series have come out from Amul also with respect to Wuhan se yahan le aaye, Amul homecoming snack. There's another interesting shot in the arm, Janta. Amul, wax below, packs below. How creative, isn't it? It gives a dash of humor. This is real creative messaging. India becomes a vaccination. So because we are the largest producers and consumers of vaccine, Amul, shot in the arm. What a beautiful pun there. Better saaf than sorry. How nice, isn't it? Amul girl is advising us to wash our hands frequently. And we also offer some interesting products, by the way, for hand hygiene and oral hygiene. Stay healthy, not hungry. That's what Amul says, lockdown in bread. Ye karwana padega. That means we'll have to flatten the curve, flatten it in bread. Oh, how delightfully creative. No waiting till you are 18. Amul, you are short of butter. Well, Amul has also brought out some interesting products, but we have these sort of humor situations and creating the seriousness for COVID. Dr. Mayank Amin, he is the Superman pharmacist of Pennsylvania, USA, who is providing all the vaccination shots in the Superman dress. So he is basically a skip pack pharmacy owner, and he is having a waiting list of 35,000 people for giving the vaccination shots. He went to a university college for pharmacy, and then he did his MBA from a B school at Villanova. And he worked at Pfizer, and he also gave that, and he's currently giving that Pfizer vaccine. So this is that Superman pharmacist of Pennsylvania. Look at other interesting communication strategies. Here, a particular ad says, regarding wearing the mask, nurses do for 12 hours. You can do for 12 minutes. Wear the mask. Wear the mask. Thank you for wearing a mask in the store. And what a very intelligent way of projecting that wearing the mask is a good behavior. He says it is respectful. This is one ad in Los Angeles. And you may be knowing that women have suffered a lot due to domestic violence. So here what the editorial says, wear the mask and women's safety, mouth covered but not silent. How very intelligent in conveying the message. And this is very interesting. McDonald's says, I am homing it, which means that stay at home, I will deliver at home. And this is a very nice Hershey Kisses chocolate ad for Mom's Day regarding social distancing also. A Hershey kiss for mom, spread love from a distance. Oh, how nice. Pregnancy and delivery during COVID-19 times, there were very good advertisements also to strengthen the confidence in such women. Dettol came out with a very interesting ad on hands washing and hand hygiene. And WHO reiterated that smoking damages your lungs and other parts of the body, and you may increase your risk for getting a severe case of COVID-19. And this was very interesting. When you ride together, you ride with Corona. Do not go to shops, hardware stores, or malls in groups. And the last one takes the cake. Greetings without contact. Salamul Namaste. So it's a combination of Amul and Salam and Namaste. Amul, greet the treat. What a beautiful ad. So all these ads created the smile in your face, didn't it? Because smiling activates the release of happy neuropeptides and hormones, dopamine, endorphins, serotonin, etc. And we all like to see smiling children, don't we? That's because children and babies smile 400 times a day. Happy people smile 52 times a day. And the average people smile only 20 times a day. And it is seen as per the facial feedback hypothesis that if you smile, neuropeptide level goes up, the happy neuropeptide, and when that level goes up, you smile better. So we, Group Pharmaceuticals, have always been partnering with dentists who is the smile and laugh and success creator. We salute the dentist because he is the one who makes you smile and laugh without hesitation. And at Group Pharmaceuticals, which is dedicating to healthy smiles and laughter, we offer a range of interesting products, including Shy-XT, which is with potassium nitrate, and nanohydroxyapatite, the only one, and fluoride. This is the bioactive glass toothpaste, Shy-NM. Elsens is the fluoridated bioactive glass. Omnident is a very unique formulation to reduce the viral load, gum bleeding, and also improve the gum health. And Fresh Chlor, of course, reducing the viral load at the chairside procedures. So a dentist is a person who not only takes away your dental pain, but also it changes your destiny by improving the smile index. And it is my privilege to introduce Dr. Mahesh Chauhan, sir, who is a gold medalist graduate from Maulana Azad Institute of Dental Sciences, Delhi University, 1990. Then he went for a short time to USA, where he was the adjunct assistant professor at Ohio State University College of Dentistry. However, he came back in 1995 and he established the Mother Dental Implant Clinic. And he has been in clinical practice for 25 years now with a more focus on oral implantology, restorative dentistry, and aesthetic dentistry. He has been the faculty in many implant courses, chaired many scientific sessions, and also has numerous publications, national and international, to his credit. This is the book which he has written, and it is a well-known book because it is a focus on fiber-reinforced composites in dentistry. His name has been featured in Marquis Who's and Who in the 6th edition published from USA. So definitely we suggest you go out for this book because it will give a lot of information and insight on how to use the reinforced composites. So thank you very much for coming in. And now over to Dr. Mahesh Chauhan, sir, where he strikes a great pose with that book which he has authored, his labor of love. Thank you very much, Dr. Mahesh Chauhan, sir. Over to you.
Thank you. Thank you, Mr. Sunil, for those very kind and very dynamic and very, uplifting words of introduction. And I thank all the participants for being here with us this evening, this Saturday evening. And I thank Group Pharma for organizing such a nice educational event. And what a beautiful introduction to introduce with, most other smile campaigns by other companies such as Amul and all that. When Sunil sir, when you introduce Amul, I immediately, thought upon, because Amul is also taking all the, women and all the, small farmers and people who raise cattle. And it's a big effort on the scale of community. So that is also forming a group. So it rhymes very well with your company also, which has always taken very good care of dentists and has taken out so many innovative products, which, I also personally like to use them. And they give a very nice feeling to our patients when they use them. And we can, prescribe them with confidence because they are of the highest quality. So welcome everybody. And as every discussion here and everywhere and news and whatever you say is about the pandemic. So of course it has been very hard to many people, but it has also taught lesson in many respects, because as the virus has been named COVID by WHO, there are scientific reasons for that, but in the word Sanskrit, COVID means Pandit. Pandit, that means a scholar. So it is a scholar which maybe is awakening everybody to be more cautious about, cross infections, hygiene, infection control practices, and things like that. So I always am looking for, improving my scientific technique and clinical technique in dentistry. So when this kind of forced, lockdown came upon, I thought that, okay, let me put whatever, educational thoughts and feelings and techniques that I've been using myself over the years, although I have been publishing them in many journals like Dental Practice. And the last issue, I published an article about, infection control guidelines. This is in Dental Practice September and October edition. And many unanswered questions like extraoral suction, etc., which the dentist had, I tried to answer them there. But we are at a very good position because we understand infection control very good, being dentists, because mouth is an environment full of, billions of bacteria. We all know that. And, asepsis and infection control should be our cornerstone whenever we are entering the dental clinic, for the benefit of our staff, our patients, and all of us. So when these guidelines came by CDC and by Indian associations and the Dental Council of India, etc., then suddenly, I was looking at the stock of my birds. I said, no rotary, no aerosol, no nothing. What will I do with all these birds? But luckily, here I have, a lecture dedicated to chairside use of fiber reinforced composites. These are wonderful materials, and we can practice all these things by using minimum aerosol generating procedures. So let me show you over the past half an hour or so how to use them correctly. So my first very slide says, speaks and shows you about the correct placement of the fiber splint. Now, fiber reinforced composite we can use in many indications, as I will come, step by step. But this is the first slide that is also teaching us the position of the splint, where it should be kept. So we see it in the upper 1/3 of the teeth on the lingual side. So that is where the position of the fiber splint would be. What is the rationale for splinting? Hypermobile teeth with reduced hard and soft tissue support benefit by splinting them together and by eliminating and treatment of disease and etiologic factors. So this was also my article published in Quintessence, and also other scientists like Area of FRC also have stressed upon this need. So we must reduce the disease causing factor and the disease itself, that is by periodontal management, and then we can think about splinting if it is required. Ways of stabilization hypermobile teeth have been resin and resin composites, as by Obin, etc., wire and wire mesh, amalgam, embedded wire, and woven polyethylene ribbon, such as in ribond material. Then there is pre-impregnated glass fiber composite combinations, which are also available, and there is fiber and composite combinations which are available. So various materials have been used to stabilize the teeth. So let us understand from the basic what are FRC. Interestingly, I would tell you that FRC materials are used extensively in aeronautics, aerospace, and making bridges, and so much in automobile industry and other industries also, because they are light in weight, they are very strong, they don't rust, there is no shelf life of the material which we store with us, and also they have very good strength, very good tensile strength, very good compressive strength as well. So it is a fiber material which is held together by a resinous matrix. This is a very, very simple and almost inclusive definition of fiber reinforced composite materials. Fiber composite incorporate about 45% of glass fibers, and they have a flexure modulus in the range of 30 gigapascals and flexure strength of about 1000 megapascals. So these values are about 10 times greater than that for dental resins alone. So that is why we see the trend of some companies and manufacturers also, which are now incorporating even small strengths of fiber materials in their composites also. So coming to the steps in using FRC, as I told you, my lecture and my new book is also about using all things chairside. So we are not dependent on any very expensive equipment or CT scans for planning or laboratory network or something else. We can do most of the things chairside. So the steps in using FRC are isolation, as it goes for most of the adhesive and restorative dentistry procedures. And before that, I would also like to mention that if the periodontal status of the person is not good, we must bring the patient to good periodontal health. So after bringing the patient to a good periodontal health, we will go ahead with our FRC procedures, that is isolation. Then there is tooth surface preparation. Now in tooth surface preparations, there are some people who advocate the making of a channel on the back side of the teeth by burr. So there is no need to make a channel on the lingual side of the teeth, and just refreshing of the surface by a red band, that is a fine diamond, is enough. So we can just refresh the teeth by rotary diamond, and the proximal surface we can refresh by finishing strips. Then after isolation and tooth surface preparation, we do acid conditioning. That is our normal phosphoric acid, And if we are working in enamel only, we would etch for 45 seconds. If it is enamel and dentin together, we would etch for less, that is around 20 seconds. Then we would wash and dry it. Then we will wash and dry the surface as we usually do for composite. Then comes the primer. What the priming step does is it facilitates the entry of the bonding agent in the dentin area, if there is a dentin area. If there is no dentin area, we can even skip the primer step and we can straight away come to the bonding step. Now, as we apply bonding agent to the teeth, we soak the pre-measured fiber splint in bonding agent. What I am talking about, Fiber Splint is a FRC material by Polydentia. That's a Swiss manufacturer. And in my book, which I will be, showing you the details some little later, all the manufacturers are given where they come. And also in the upcoming article of Journal Dental Practice, also you will get to know where to find these materials. They will be available all over India. And they were available before also. In between, there was a little short supply, but they are available worldwide. And in India also, now on, they will be available. Applying and adapting it closely to the tooth surface and then light curing. So this is an important thing for you to note, that when we apply bonding agent to the teeth after etching, we don't cure that bonding agent. Please note that. We apply the fiber splint along with the bonding agent, we adapt it very nicely and then we cure it. So please note that we don't cure the bonding agent, we cure the bonding agent and the FRC material together. Okay? Then we check the occlusion and then we do the finishing and polishing. So material use, as I told you, is the Fiber Splint by Polydentia. It's a Swiss company which make many of other materials also, like mattresses and number of products. It's a woven fabric like fiberglass material in a strip form bonded onto the tooth structure with adhesive resin. The beauty of this material is also that it has got no expiry date. You buy it today, it comes in a 50-meter spool and you can use it after 10 years, no problem, because it has got an almost indefinite shelf life. Of course, your bonding agent will have a shelf life, but you can use the same bonding agent that you use for the teeth and fillings and sealants and whatnot. So it's a very nice material, and for me it has been a must-have, and I'm using it since 1990. In my book, there is a case follow-up of more than 15 years for this. Although I have many follow-ups of more than 25 years. Using this material, but I have documented, cases which are 7 years, 10 years, 15 years in follow-up. So this is how we take it. We measure it according to the length of the teeth and also taking into consideration the interproximal areas, because we would like to adapt it well into the interproximal areas. So if the teeth area is X, we have to add a little bit of the interdental area also, where we will be adapting it. I will show you in the next slides how we adapt it. So we take it and we soak it in the bonding agent. As it goes with all light sensitive materials, when we dispense the bonding agent, we must be aware of the ambient light of the room and we must cover it with an opaque object. Any opaque object would be fine. It can be a plastic bowl or whatever you have handy. It should be clean and it should be used as soon as possible in the mouth. So this is the slide showing the area of application. It's in the incisive 1/3 of the teeth, as I told you earlier. Now what I use these fine explorers. These are very fine explorers, and you can cure while the explorer is in the place. The explorer will not stick because it is very slender. You can just twist it and lift it up. So when the explorer is on, the assistant will light cure the material so that it is nicely adapted to the teeth. Another method to adapt the fiber splint material to the teeth is use of putty matrix. You can create an index like that of A silicon or C silicon putty, and when you apply fiber splint, as it is shown by arrows here, you can apply, put it on the teeth, and apply the putty index that will adapt the fiber splint in a very good way to the lingual side of the teeth. And then you can light cure from the labial side initially, then remove the index, and then cure it from the lingual side as well. So this is how it is done. The fiber splint material is sandwiched in between the putty and the teeth. Is another view showing the adaptation, and here it is after adaptation is done and curing is done. Now you can remove the matrix and cure it fully onto the lingual side, and then we will be adding composite over the fiber splint material so that it is all covered with composite material. So this was the technique in brief. In detail it is given in the book, which you can now access on Amazon. And rationale of splinting in tooth injury. Injured anterior teeth needing stabilization, such as in luxation, we fix for 2 to 3 weeks only. So now that was periodontal splinting, that is indefinite. This is in injury. Injury, luxation 2 to 3 weeks, subluxation 1 to 2 weeks, extrusion 1 to 2 weeks. So here in the case of injury, we would like to stabilize the teeth by splinting for short duration, not a long duration. The rationale for short duration is that we allow periodontal fibers to repair rather than bony healing. So we don't need ankylosis there. Splinting time of less than 3 weeks is recommended. To stabilize a root fracture, however, a longer splinting time is indicated, such as 1 month to 3 months, as this will allow calcified tissue to heal. But in those cases, of course, you have to keep a watch on the tooth, do a root canal, and then look for any signs that if it is becoming non-vital, then you have to extract it if the root fracture is there. But otherwise, in luxation, subluxation, we do an endo, we do splinting, and tooth will serve for very long years. So it is for the clinician to evaluate the tooth for vitality, and RCT should be done wherever indicated. RCT access can be gained through the fiber splint if it has been applied lingually. That is later on. You splint it today, you don't want to do a root canal right away, or you are in doubt. So you can keep the splint on, and later on you can do the RCT through the splint. So many times isolation in recent tooth injury is a problem. So we can apply fiber splint on the labial side of the tooth. What is the splint duration for periodontally weak teeth? It is indefinite. And what are the benefits? If we look, it allows the patient to chew comfortably. So teeth were mobile, teeth are fixed now, so one can chew comfortably. Mobile teeth become firm, therefore allowing the patient to maintain better hygiene, because otherwise they are sometimes afraid to brush them. They say it is mobile, if I brush it will come out. So that is not the case. Splinting can use regular brush. Splinted teeth, patient can use a regular brush, interdental brush, etc. without the fear of looking down, knocking out the teeth. And splinting is done in conjunction with other periodontal therapies such as scaling, curettage, root planning, and flap surgery. It is also an adjunct to preservation of soft and hard tissue. It enhances patient self-confidence. So there are so many benefits that the patient do appreciate when we render them this treatment. Then, as in case of injury, splint will have to be removed at some point. While periodontal splinting did not be removed, but even if that has to be removed for some reason, then we use a 6 fluted carbide burrs using water spray and high vacuum suction. To check the complete removal, we dry the tooth in between. That way we can see where is the composite or the splint material and where is the enamel. We don't want to damage the enamel in removing the splint. So let us come to clinical cases one by one. This is splinting of periodontally weak teeth and post-trauma or luxated teeth. So this is a case of periodontally weak teeth. There is a lingual side scaling and root planning procedures have been completed, and now there is no active gingival exudate for this patient. So here I am using a material which is a clear silicon index. It is called Fiberglass, and there are other companies also which make it. Kulzer makes it, GC makes it, and Polydentia makes it. So this is a silicon material which is a clear index, and this is how it is formed. So once the teeth are clean and we can form an index like this, what this will do is this will help us adapt the fiber splint material lingual side. We etch the teeth, etching in between. Then we apply our fiber splint. Here it is fiber splint multi-layer. So this is a 6 splint stitch in one. And then we apply our index and we cure through the index. So the transparent index is allowing light to pass through it. But mind you, this light curing will be minimal. It won't be the desired light curing. So we have to remove the index and light cure them again at a close range for the full intensity of the light to reach there. We hold it closely with our finger on the lingual side now, and we light cure it from the labial side. So this is light curing for the labial side or the interproximal areas where our splinting material is there. And now we can see the well-adapted splint. So the real key is to adapt it really well and have the light curing reaction complete. And after the splint has been cured, we cover it entirely with composite resin. It can be any syringe composite resin. There is no specificity. And then it is polished and shaped like teeth. So you see in this slide that the cervical area of the teeth have been left completely without any coverage so that patient can maintain good hygiene. And we check the occlusion for any high point at this stage. And we allow and teach the patient to use interdental brush for proximal cleaning. So that was an example of a good splinting that I showed. Now I'll show you what is a bad splinting. So these are the honeybees on my terrace garden, and I'm very fond of flowers and keeping a garden. So since there are many flowers, there are many bees also, and I'm so happy to see them thriving there. So this was a wrong approach to splinting. This is a patient who came to my clinic, just a few days back, and you can see, although he has beautiful gold crowns done, these crowns were done not by me, but by another famous dentist of Delhi, Dr. Avinash Nair, whose son is also a professor in USA, Dr. Arun Nair. So these crowns are almost 40 to 45 years old, serving very well to the patient. But then he went to some local dentist in his area, and he said that my teeth are mobile. So immediately what the dentist did, even without telling the patient what he is doing, why is he doing, he took some cold cure and put them between the teeth in the cervical area. And you can see how ugly it looks and what a magnet for calculus it is. So this has to be removed, and the dentist never bothered to treat the periapical pathology that was there in the teeth. So this is an example of a bad way of so-called splinting. I would not even call it splinting, I would call it quackery. So does good splinting last long? Of course it lasts long. Any good dental work lasts very long. So this is a 12-year follow-up of one of my patients in which I did splinting, and you can see the heavy wear on the teeth. So the splint is holding the teeth very well, and the patient is able to use their teeth very well, and you can see the excellent health of the gingiva there also. In fact, this is not only splinting, this is a natural tooth pontic, a topic on which I am coming now. So the central incisor there you see on the left side has got no root. The root has been cut. It is a natural tooth pontic held together by the splinting, and this is a 12-year follow-up of the patient. This is not the same patient I showed you just before. That was this is another patient of mine. So what is a natural tooth pontic? that is reusing patient's own incisor tooth as a pontic. This is done for those incisor teeth that are due for extraction. So patient is very happy they are having their own tooth back. And sometimes the patient don't keep the tooth, they throw it away. Then in that case, what to do? Or the tooth is too much decayed, what to do? Then we can use a denture tooth also. That is a denture tooth pontic. And we can bond it to composite. Many a times when I do some lectures, etc., people ask me that will any denture tooth bind? Yes, almost any denture tooth will bind to the bonding agents and the fiber splint material that we use. But we must roughen the surface of the denture tooth little bit and then apply the proper protocol of splinting. So this is the natural tooth of the patient, upper central incisor, periodontal involvement. The tooth had to be extracted. And when we extract this tooth, we put it with fiber splint. And this is a natural tooth pontic, as you can say. The root is not there, but it looks as if the tooth is there with the root. Palatal side splinting has been done. So we see the case of mandibular NTP. That was a case of maxillary NTP. This is the case of mandibular NTP. And the flower you see here is a beautiful Kachnar flower. So Kachnar is a very, very aesthetic, and around Holi, the whole tree flowers, and this looks like the famous cherry blossom trees of the Japan that are famous worldwide. But Kachnar is a resident of Delhi, and previously we had many Kachnar trees, but now we have less of Kachnar trees in the garden in front of my house, and we have more of the other non-flowering trees like Ashoka and fig tree like that. So this is an example of the mandibular incisor which I used as a natural tooth pontic. Here it is, and this is a very old photograph from my patient. In those days I used to use the Fujifilm chrome, which was not digital, of course. So that those digital things have been converted into non-digital things. Analog have been converted into digital, and sharing with you here. This is a case from 2002. Twin NTP. This was an extreme case in which I did one central incisor as a natural tooth pontic. Then after some time, the splint was still on. The other tooth became periodontally involved. So the other tooth also root I cut. And this patient had another problem. There was big black triangles there and gap. Her gingiva was receded. So what I made for this patient was a heat cure acrylic resin, artificial gingiva like this. So patient can put them on and put them off like goggles. She can just snap fit them. There is no need to stick them or glue them with anything. Just by undercut, they are retained very well. So this is a photograph after the artificial gingiva has been put in the upper jaw. And this is the lingual view. See how beautifully the fiber splint is holding. And a really good thing to note here is that the canines are not involved. It is only the lateral incisor. So there is a lot of big logic that I'll be presenting in my book, because this is 240 pages and this lecture will not allow me to speak that much. What is the logic of not splinting and not connecting to the canine? So I have almost never connected canine. Only in rare cases I have connected canine. Otherwise I would just connect the incisors. And this is a finishing strip by Polydentia I'm using just to show and just to demonstrate you that there is no root of this tooth. This is another demonstration. There is no root of this tooth and the other tooth. So both the teeth are natural tooth pontic, and this patient is with me for this, the same prosthetic rehabilitation. Almost it has been now almost a decade now that this patient is functioning well with this kind of thing. Another example, natural tooth pontic. There is a tooth, we mark it to cut the root, and what you see in the right upper corner After we cut the root, we extirpate the dead pulp and seal it with composite. And now it is ready for the natural tooth pontic position. And in this case, there was no space on the palatal side, so I used the splint on the labial side. You can see in the slide, the fiber splint is well adapted on the labial side. But then I thought the labial side might not be enough for this patient, so I created some space by doing a little softless disking on the linguals, on the incisal edges of the lower teeth, and little bit disking on the surface, on the lingual surface of the teeth, and I applied fiber splint multi-layer on the lingual side, palatal side as well. So this is a kind of sandwich between the labial side and the lingual side both. So I can be assured that this is a very strong splinting that will work. So I have connected not even 4 teeth, I have connected just 3 teeth here. No canines, no lateral incisor of other side. So like you have a 3-unit porcelain fused to metal or a zirconia bridge, this is a 3-unit bridge, entirely chairside, very economical. Patient is very happy, and all that this takes is around 2 hours, and you can be done. So FRC with acrylic tooth pontic. As I told you, what to do when the patient doesn't have his or her own tooth. We use acrylic tooth. I like the video. So here is the patient, missing tooth, and as you can see from the skin texture, this is a very young patient. So he has knocked out his tooth somewhere, and this is the radiograph of the patient. And you can see the palatal view. Now we have options of course, implant. We have the option of course, the bridge. But here, the patient wants something to be done very quickly and very economically. So I am also in favor of such a processes, which I am just going to show you now. Gingival health must be established, and then I select the tooth. So it is better to select a very nice denture tooth, which is multi-layer and which looks just like a natural tooth. So here it is. I have cut and adjusted it to fit, and this is the palatal view. So this is a perfect size fit, and just by resistance of the adjacent teeth, this tooth is fixing there well. So I have a little retention form on the palatal side and the proximal side of the tooth. And here is the etching in the proximal side, and the palatal side was etched as well. And here is a denture tooth fixed with fiber splint material. This is the palatal side, as you can see, very clean and very minimal intervention. You can see the clear matrix separating from the adjacent teeth. Etching 1 minute here. Washing and drying and applying bonding agent. No curing after applying bonding agent. We apply this material, fiber splint multi-layer, which are 6 layers. 6 layers are like this. We cut them with serrated scissors. Dispense our fiber bond onto the glass slab. Let the material soak completely in fiber bond, and apply it, adapt it well onto the palatal side. Then we cover it with composite resin and light cure it. And this is after finishing. This is after finishing the procedure, not after finishing or polishing procedure. So you can see minimum I have to do in terms of grinding or whatever. This is a palatal view after finishing. It looks very comfortable. It seems very comfortable to the tongue of the patient also. And this is good for hygiene maintenance by the patient also. And this is a smile of the patient. And this is a radiograph of the patient. This is a denture tooth. So this is a case of a mandibular incisor. The flower you see here is a paper flower and blossoms for very few days only in March. And mandibular case, no tooth with the patient, so I have to select a denture tooth. Denture tooth has been selected. And what I do here is use a little composite without etching and bonding and have a little wire stick to the labial side of the teeth and apply with a little flowable composite to the adjacent teeth. So adjacent teeth and this wire and this composite without etching and without bonding is holding the tooth in its position. So I don't need a second assistant. This is doing my job. And then I apply my fiber splint material. And after all the steps which I showed in the previous cases, I will do my finishing and polishing. The strip here I am using is the Epitex by GC. And this is the tooth as it looks. So very comfortable to the tongue also, very economical and very aesthetic. Now we have to manage some modifications also. And as I told you, yes, FRC materials are a long-term materials. That is not a quick fix. This patient had less space, so I etch and use the labial side for putting the fiber splint material. And this is a 5-year follow-up of the patient. After some years, what happened? The adjacent tooth developed some periapical pathology, so it had to be cut. So on the right and bottom slide number 4, you can see I don't disturb the FRC at all. I just cut the lingual, I just cut the root portion of the tooth after giving anesthesia, and this can go on like this. You can see the root has been removed. I strip it, I make it smooth, and now this is a double teeth natural tooth pontic held together by fiber splint. So all these procedures I have been doing, I have been doing it since my internship in 1990. So from 1990 to now, it has almost been 30 years that I have been using splinting protocols, and mostly what I use is this polydentia materials. And as I told you, this lockdown gave me a time to, although I have done lectures, seminars and hands-on courses on this technique, but then I wanted to put it in a very consolidated way. So I put it in a very consolidated way on this book title, which is having a lot of clinical cases and 300 color images. And every case is followed by, the logic, why I did, how I treated this case, what were the other differential diagnosis options, and step by step. So, and this is a very economically priced book, now available on Amazon worldwide, and I would really recommend you, because it also has a section of periodontal, and it has a section on the prosthetic bonding agents also. So, and it is by a very reputed publisher, Wiley, which also publishes many of our dental journals. So it will be something that you would really like. I would recommend that. And also all the materials which are being used here, they are also listed there. Another application area of FRC is orthodontics. You can use a retainer post-orthodontic therapy and space maintenance. So this was also an old case, orthodontic treatment and space and lost tooth. So this was a lost tooth which was replanted. So again, root has been cut, it has been sealed from the top side, and I use fiber splint to bond it with adjacent tooth like this. Now this is the ongoing orthodontic treatment and tooth movement is there, so I bond it from one side. So this is a cantilever, and this is a temporary process, not forever. So this is cantilevered. I don't want to bond it both sides, because then the orthodontist has no space to move the teeth where they want to move it. Implant dentistry application now is in application as a temporary bridge for few months, especially in cases where we are doing grafting procedures. This patient had underwent endo somewhere, underwent episectomy, and there was no bone. As you can see, the ridge is very narrow, flat, damaged, and there is amalgam tattoo as well. So I opened, I could not resist putting an implant slide because I'm an implantologist. So I said, okay, let me combine FRC and implant knowledge together. So here I put it here. So the ridge is very narrow and you can see a deep defect on the buccal side. And I use bone expansion. After first drilling, I use bone expansion and then put my implant slowly. The implant here is a leader Tixos MC implant. And put some bone grafting material. This is synthetic bone grafting material. For ethical reasons, I don't use any animal bone graft materials. See what has happened in the world after too much exploitation of animals. We have this virus and that virus and pandemic and what to talk. We are just, not taking care of the nature of the environment, or we should respect our planet more than what we are giving it now. Put the membrane, suture it, and then select a denture tooth and put the Fiber Splint ML on the labial side. So here my splinting, I am designing it to last just for 4 months, 5 months. That's it. Till the grafting integrates and the implant integrates. And then I am ready to remove it. Of course, implant crown will come there. This is when it is ready to remove. And I remove it, and of course implant crown will follow. That will not cover in this lecture, maybe some other. Another application area will be reinforcing old bridges and dentures. There are some patients, who keep on breaking their upper dentures, especially when the lower teeth are, the permanent teeth. So we can reinforce with fiber FRC materials. So there are some future applications like edge repair. This is very exciting, and this has not been listed in literature almost anywhere. These are my own, methods which I have followed it for more than 12 years and listed many of these cases in my new book. Fracture tooth, as you can see, this is also a case of 2002. I apply FRC and I apply composite in the regular manner. I join the broken portion back. So this is like a tape which is, sticking the teeth together, and this holds on. And cover it with composite, of course. 3 teeth together. These kids were swimming in the swimming pool and he hit the wall, of the border of the swimming pool. They were throwing coins and collecting coins from the bottom. So it was too excited, and somehow his cousins were with him and they managed to bring all these 3 pieces together from the pool, because playing that, finding the coin game, they had become so expert in, finding them. They found the broken teeth like pearls. Brought them to me, and I stick them together using Fiber Splint and composite combinations. Of course, the direction of the teeth later on orthodontics can be taken up if the patient wishes, but here the patient's own tooth has been fixed. This is a picture of the holy basilica. Holy basil leaves. And another case in which 2 teeth were broken. And you see a close bite situation. It's a challenge. Of course, the pulp was exposed, so we had to do root canal treatment. These were the 2 segments, and we did the root canal and stuck the teeth together. Using Fiber Splint, attaching the fragment, covering it with composite. combination application of FRC. We are nearing the end of the lecture. So this was an extreme engineering that I used with Fiber Splint. I used it as an internal framework for crown, as an external framework for FPD, and for retaining NTP. So all these things combined I use in one case only. This was like this. So this was a tooth which was replanted and had underwent internal resorption. So, and the adjacent teeth needed root canal and a crown. So as you can see in the collage of these slides, that I use a Fiber Splint material to fix all the problems together, and use the Fiber Splint in a Z form. And I used it little indirect method, and I fabricated this on the cast. And here is the patient after the restoration. Everything chair side, no lab work required in this case. Thank you very much. This is the blue jay butterfly, and an interesting fact is that the most of the animals and the nature, you don't see true blue color. So the blue color is a manipulation of the reflection of the fibers of the feather of this butterfly. It is not a true blue color. So in nature, it is very difficult to find a blue. So friends, this is the end of my presentation, and I thank all of you to spare your valuable time for being with me this Saturday evening, and I thank Group Pharma for being such a wonderful host for this interesting topic.
Thank you very much, Doctor. It was indeed a great pleasure to hear you speak with little flower breaks in between.
Thank you so much.
Sir, would you take 2 questions?
Yeah, sure.
Yeah, okay. So Dr. Rekha Shetty madam is asking whether the FRC can replace capping.
No, it is not a replacement for capping, but what you can do is that in case you are making a long span temporary bridge, as we have sometimes to do, then you can incorporate the FRC material in your temporization. But just to be in capping, it is extremely difficult to handle. There have been lab systems using FRC just like Targus Vectris in the past, but to do chair side for crown, it is very difficult.
Okay, sir. And second question she asks, how many sittings are required for a broken natural tooth? For one broken natural tooth, how many sittings usually?
There are aspects to consider in that. The one aspect will be whether there is a pulpal injury or not. So if there is an injury to the pulp and you are one of those dentists who would like to do single visit root canal, then you can go ahead and do a single visit root canal and fix the tooth right away in the very one long sitting. But if there are more issues, if there is lip injury also, in the lip is bleeding and you cannot achieve isolation, then you schedule another appointment and do it in the second go.
Yes. And sir, Dr. Kanika is asking, does RCT need to be done prior to extracted tooth FRC?
Yes, RCT needs to be done, but that is not the RCT in the true sense. When we are extracting the tooth, we are using only the coronal portion of the tooth, as I showed in the slides. So we remove the dead pulp from the coronal portion, we clean it, and then we seal it with a composite resin. So it looks like a denture tooth, looks like a solid tooth. There is no dead pulp inside that area.
Sir, Dr. Manish Khatri is asking, he wants you to again brief about using the putty impression technique. Will the FRC splint not stick to the putty material?
No, FRC doesn't stick to the putty. You can use A silicone putty, you can use clear A silicone putty, or you can use even C silicone putty. When we cure, the FRC sticks to the tooth because we have applied bonding agent to the tooth, not to the putty.
Okay. You are very clear, sir, and absolutely to the point when you are answering the question. And a lot of encomiums for you. Like Shambhavi is appreciating, and Dr. Grishma, All of them are just appreciating you.
Thank
and
you.
I don't see any other questions. They're all appreciations which we record, and we also thank you. Any other point you would like to make, sir, as a final note?
Just like you to thank again, because your company also has such a wonderful range of preventive. So I would really stress all the dentists to focus on the preventive dentistry more rather than surgery, because the patients also feel like कि डॉक्टर के पास जाएगा दांत उखाड़ देगा. So we don't want to remove the teeth. We want to keep the teeth. We want to restore periodontal health, and then we want to maintain those teeth by good brushing, good hygiene, and using good cleaning methods. So the focus should be always on preventive medicine, preventive dentistry, and not on doing extensive and invasive procedures. That is my way of thinking for my patients.
And doctor, plus all the attendees, we have shared the PDF of the brochure on this webinar jam itself.
Thank you.
PDF brochure of that book. So please download it. It will help you to get the book on Amazon also, and you can purchase it. So I think we can call it a day. Dr. Samatha is also appreciating you. And Dr. Archana Sachdev also. So it is flowing with a lot of what do you say, appreciation.
Thank you. My appreciation to everyone as well.
Yes. Thank you, sir. So do I take your permission and shall I close the webinar?
Thank you. Thank you.
Thank you, sir. So I shall close the webinar. Thank you very much. Thank you, attendees, for your kind presence. Thank you.